There are other studies looking at or developing prediction models for amyloid pathology. But the problem often is the distinction between when you develop something in a medical cohort or clinical cohort, so patient recruited especially from specialized memory clinics, or when you look more into population-based, representing more the general population. And my interest was not so much to develop the model, but rather to validate the model in our prospective population-based study, and to see whether we can develop these models in large patient cohorts or clinical cohorts and take them to, for example, the primary care setting where we see quite different people. And in this study, actually, we found, yeah, it was validated. So the transportability seems to be there, which was a good sign. However, if I may just take another half a minute, the overall performance of the best model wasn't as convincing. It was actually quite sobering. So this wouldn't be able to go into the clinic yet. And just why we then did the sleep study. So I looked at the top predictors, the top performing predictors for amyloid pathology. And among the 10 top predictors, there was only one modifiable one, and this was sleep. So we did the sleep study. So the strongest predictors were APOE4 carriership, so whether you carry one or two of the risk alleles, then also a family history of dementia, your sex, and your age. So these are pretty much unmodifiable. That's why I was so amazed to see that sleep was also in the top 10 predictors.